The idea behind this session, when we were engaging in the research process, one of the things that came up is the idea that IT is not an end, it's a means to an end. And when we spend all this money and all these resources and time into IT, we ultimately need to make sure that we can tie investments to some metrics to go back to the purse holders and say, look, all the money that I asked for, here's the benefits that it brought to the organization. And here's why you should give me more money next time I ask for it. And so that's the kind of idea behind the session. So we have three esteemed speakers on the stage today. To my right is Rick Moore, the CIO for the National Committee for Quality Assurance. In the middle is Tammy Gregory, the VP of Quality and Health IT at the American Heart Association. And to my far left is Victoria Richardson, the Clinical Informatics Manager at Bunsecure Health Systems, Inc. And I believe that Victoria will kick things off.
Well, actually, we've had a change.
No problem. We're flexible.
So Rick Moore is actually going to cut things off and actually talk about the hit investment and quality outcomes.
Okay. See? Impromptu. I'm ready to go. Had no idea we were changing that quick. So, can everybody see me? Probably not. Let me see if I stand over here. You better. Yeah. There we go. Can everybody hear me? Do I need to be in the mic? This one? Okay. Because you're trying to pick stuff up. I feel guilty because of all this technology around me. I think I'm supposed to put on some big show. So I hate to disappoint in case it's not as good as it should be. So I want to try not to do what I think you gave me. Is it part of 3 rules? I can't have a sales pitch, right? So can't do that. So strike one. I can't do death by PowerPoint. So I'm going to try not to do that for you, so I don't get my second strike. How many of you are familiar with the National Committee for Quality Assurance? I know. Okay, here we go. So I'm not going to belabor what we do, but I'm going to try to get down into, hopefully, and draw you guys a map, if you will, for what we believe has been a great success. And ironically enough, 5 years ago, almost to the day, we met here as a company, National Committee for Quality Assurance, at this resort to actually talk about the patient-centered medical home. And as I reflect back on that, I'm driving out here going, what a beautiful day. It's a gorgeous day out. It wasn't so gorgeous that day. I got to tell you, it was a lot colder. But what a beautiful start to the day when I drove in this morning, 2.5-hour drive in from Virginia, thinking about that time we were here, and we were talking about the patient-centered medical home. And at that time, we only had about 80 practices that had come through in 2008. So when you think back about this, I'm going to show you some numbers. We've come a long way, baby. I mean, quite a bit. And I think for those of you who are looking for ways to, my talk's more about for a roadmap for your providers out there, or those of you who work with providers, can they hear it? Oh, they want me to hold it. Now I feel like I'm on American Idol. Oh, sorry. Thank you. Sorry about that. But for those of you looking for that roadmap, or that have to counsel those that need a roadmap, like the regional extension centers and so forth, this, I believe, for you will give you some evidence to help you do that. So I already told you a little bit about what we're about. We measure quality. We're about transparency, and we believe if you don't measure it, you can't change it. And that's what we're all trying to push forward. So I just gathered a few things. You guys can go here to the same place I went to get this information. These are real live, not NCQA produced, but real live results of what the PCMH practices out there, and again, across the country, have started to see in terms of the return on their investment. We're talking real dollar savings. We're talking real quality improvement. We're talking people changing their lives. And so we believe very firmly that it's not just, as Parnham said, the IT that's doing this. We know it's the way it's being used, and we know that meaningful use actually is a part of that. So, we couldn't have never planned it to be as perfectly as it was. So in 2008, we're talking about patient-centered medical home. What happens in 2009? Our high-tech comes out. 2010, patient. We all know what's going on there. Regardless of your political affiliations, we know that those things have made folks come to the table now and have these discussions. Very hard discussions about, if we're going to invest this money and we're going to invest in this technology, how do we use it in the most effective way? So it's not just, for the lack of a better word, checking off a box that we bought something. And we believe that PCMH guideline has helped do that because there's a consensus around what those practices have to do to get there. So as you can see, this map just shows you the number of sites, and that's somewhat dated as of August. Almost 5,000 different practices across the United States. I mean, there's not a state out there except the Dakotas. We're not quite sure what's going on there, but they're the only two right now that don't have some form of patient-centered medical home going on. But 23,000, I think we're at right now, clinicians that have somehow touched the lives of others via the patient-centered medical home. And I was in the state of Vermont, it's that small state up there in the Northeast about 3 weeks ago. This is no measure of how the rest of the United States is doing, but I'm assuming it's a pretty good indicator. What was really interesting from my perspective was there were really three main themes, but two of the ones that came out that I felt were very inspiring, and to me, it helped me, connect with what I do, is the providers were feeling it really team-based for them, which is totally different than just throw a computer in front of them and, make this work. And the patients were saying the same thing, so we got the mixture to interview with some patients and providers, and they both said they felt the teamness around what was going on with their care, and the providers felt that teamness was going on inside their clinic. So those are two main themes that I thought were fantastic. And, of course, the other main theme from the provider perspective in that particular community or state was they had a funding stream, if you will, for when a practice achieved a certain level of PCMH-ness, they would actually fund a certain level of staffing to help support them. So what was really interesting about that was they were allowed to, at that particular site, and it's different for each site, right? They look at what they need in that site, and they might need a social worker at one, they might need a psychologist in another. And so they let that site, that practice site, determine what they needed inside the community. And so community by community, what we're seeing here is this phenomenal get-together, if you will, coordinating that care around the patient so that, one of the things that was interesting to me is that providers felt very encumbered by the fact that they knew their patient might need some help that they couldn't give them. And they just couldn't do it because, one, it wasn't, I hate to say, wasn't a billable event per se, but they had no one to refer them to. But now they've got the social worker that's helping them do these things that they know is needed, so the whole person is really being taken care of as opposed to just came in for a cold. But they actually talk to them about other things like, well, what are the needs of the rest of the family? And they find out things about the children that are going on that are affecting them, the stress in the family. And so you get this whole person concept going. That's where we believe these patient-centered medical homes are having a major difference on the lives of others. A little bit about the standards. If you're not familiar with them, I was talking to someone today at the table. There's not very many standards, quite frankly, and we like to tell you that it's descriptive, not prescriptive, meaning we describe what it is, the what. We don't really prescribe the how. So part of the evaluation process is helping each site understand how they take these whats and turn them into hows. And so the thing that I was showing you earlier about the results, those studies actually went in, and we have a lot of research now around some of the hows. I mean, but bottom line, it's provider. I mean, at the end of the day, folks, it's provider leadership is number one, and that transformative leadership has to happen at the provider level. It truly has to happen. It's that team-based, who's doing what with each one of these standards. And again, it's not throwing the computer in front of the doctor and saying, make care better. It's providing that system of intercommunication, interconnectedness, both with the provider team and the patient, as well as the rest of the community. So these standards get at some of those. You can start to look at these, access and continuity, identity, manage your patient population, know who's out there that's ill to bring them in, your diabetics, your asthmatics. Look at your case management around these particular disease cases and these individuals that need additional care. Support self-care process. So these that I'm looking at in the bolds, these are what we call our must-pass elements. So you have to pass those elements out of every one of the standards areas that we have, and you can see that it's not that many out of all of those areas, and there's a lot of research that goes on to see how many of these, in addition to the must-pass, are we actually finding that are drawing in, if you will, a more refined use of EHR technologies. And to that degree, what we actually are starting, and we're those of you who might be in the vendor community with EHRs, we now have what we're calling a PCMH pre-validation for software vendors. So it's relatively new. We have about 2 that have gone through it and 3 more that are actually in the queue, where they bring to us their software. And we look at these standards and we say, okay, show us where you think, some of the how, show us where you think your software would facilitate these standards for the provider. Now, at the end of the day, the provider still has to show us proof, right, that they've done these things. You can't just say, well, yeah, I have CPOE, therefore I'm using it, right? So you still have to show us that report during the evaluation phases, but what we do is we pre-validate that software for the vendors, and they're allowed to be, if you will, go out and tell folks that are buying their software, hey, if you use these functions, we know that NCQA already agrees with us that these would help meet those standards for you. So that's another area that we're trying to tie the two together. So when you go out and do these investments, bottom line for us is what we want to, the message out of this, the takeaway is that we tie together and we align with meaningful use. We want to make sure that when the providers are out there, particularly in our 2011 standards, even though it was implicit before, if you will, in our what we call our 2008 standards, by 2011, we aligned and specifically stated certain things in our standards that basically go right back to the meaningful use standards. So it's you can't hardly miss it. In fact, I provide you at the end of this presentation a map for that. Yes, sir.
Just wondering, what do you provide the vendor once they come in and do that?
So we provide the vendor. So we give them feedback that says, okay, out of the functionalities you've showed us, we believe these areas match up with the standards, and we give you back what, in some cases, it gets as close as, gets as good as auto credit. Now, auto credit's pretty phenomenal, although that's very rare. Auto credit means this standard, if you're using the software, we don't even have to see the proof, it's auto credit. We know that you're using that software, you get the 2, 10, whatever the number of points are, quite frankly. Other areas, what we say is, yes, that functionality, what we call pre-validated, that functionality does mean, so we give that back to the vendor and say, this version of your software does what you say. Now, when it's implemented, everyone knows implementation is different than what was in the box. Once you take it off the shelf and put it in, where we as NCQA can't see, implementation, we actually, that's where I was saying before, you still have to show us the proof. So we would give the provider back the right to say, here's what you can advertise as a provider. And some of these are service providers, by the way. Some are pure software, but some are also service side. So, example, I'll name one that's on our website, Fitel. They provide more service-based, hosted services for providers and back-end sort of office management stuff. But they don't necessarily provide EHR software, right? So, exactly. We're not doing the certification. We're not part of the meaningful use certification criteria. So I'm glad you asked that question. They're different aspects altogether. Great point. I don't know where you're from, but that's an excellent point, and a lot of folks ask that. They would love to have, where could I go? I'm sure I see a regional extension center mind here. Where can I go to get that one bag of tricks that shows me all the pieces I need, right? Because as we all know, one of the things we want to be able to do in this innovation of electronic health records, if you will, is there's that baseline functionality that's in meaningful use, right? And then there's all these other pieces that would really help. And that's where some of these third-party service providers are coming in to help, interact between what was in that meaningful use certified piece of software and what makes my practice more efficient and effective, if you will. There's really no, if you will, one-stop shop for that kind of certification. I think the criteria is ramping up. I know there's discussions about usability, and I believe other folks are going to talk about that in another session possibly, so I don't want to steal their thunder. But that's where we have the difference. Did that answer your question? Any other questions before I move on real quick? So I'm going to end right here actually with the death by PowerPoint. And I included these other slides for you basically that go into, this map just shows a very illustrative view of what we mean by what the PCMH and how it aligns with meaningful use. Sort of that one-pager for folks. It's a lot of information. But again, if you really want to get into the details and find out where these standards actually align, I provided you each one of these, and where they're blue, there's implicit use of each HIT, and you could probably draw corollaries to other standards as well. But I left those in there just for your own use, and I really wanted to have more time for folks to ask questions. So I'll pass it over to, I think, Tammy now. You're going to go. Yeah, you're taller than me, so that might be able to see you.
Let me just scroll through. Okay, so I'm actually just going to tell you a little bit of a story. I know our case study, or I'm just going to present a case study of one example of a quality improvement program that used health IT and got fairly good results. But I think, the message that I really am trying to articulate with this talk is really that it takes a lot of pieces, kind of health IT by itself, which I think was said when we first started this, is really a means to an end. And to us, for the American Heart Association, the end is really improved patient care, which I think is the same for everybody in this room, actually. And so about 10 years ago, in 2000, we started a little bit of an experiment called quality improvement within the Heart Association. We've been putting out scientific guidelines for decades and trying to, kind of inform science and evidence around what is the right patient care to be delivered in certain settings. But not until 2000 did we actually start to implement a program called Get With the Guidelines in the hospital setting that helped hospitals and healthcare providers, whether it's nurses or physicians, implement those guidelines. So this was really the first time that we had started to do that. Since that time, that program has been adopted in 2,000 unique hospitals across the country, and this just represents, kind of the geographic distribution of those hospitals. We have modules for heart attack patients, for heart failure patients, for stroke patients, which is our largest module that hospitals are participating in, with 1,600 hospitals participating in that one. We have Action Registry Get With the Guidelines, which is a program that we do with our partners at American College of Cardiology. But basically, this is a program really that has not just helped hospitals do continuous quality improvement, but it's also generated quite a bit of science and evidence itself. So we've published over 200 papers, just went over 201 this last week, that kind of describe the experience with those 4 million patient records that we've been collecting over the last decade. And some of the papers are kind of about the program's effectiveness and whether it works in certain settings, and some of the papers are really about kind of smaller cohort analyses. So an example is ICD placement in females with heart failure over 60. So you can get very detailed in those analyses. But what I really want to drive home is that this program is not a registry. I think there's lots of registries. They're even kind of really articulated in meaningful use now around connection with registries, but it really is about continuous quality improvement. And it started as that back 10 years ago, and really was trying to collect only the data that was needed to inform the care of the patients around certain guidelines. So we really did try and keep it very streamlined. Over time, it has grown because we have researchers that are at the helm of our volunteer committees, and they, want to find the answers to more questions. So it has grown, but we still try and walk that balance between quality improvement and research, and try and fall further on the quality improvement side of things. It really is about taking evidence-based medicine and helping the hospital and the providers implement that. So, there's a story about a physician that manages quite a few cardiologists in Chicago, 155 cardiology member practice, and he would say to me in the beginning, this data must be wrong because it's saying that our providers are sometimes in the 70% of their performance, and these are thoroughbred cardiologists that are not used to getting a C. They've been A students their whole life. And so that's always the first question: the data is wrong. And so then you present the data back, and you kind of look back and forth, and actually it's not wrong, and they are performing at 70% on some measures, and that alone had motivated them to change. And so really looking at their data as well as being compared to the aggregate. So if they could see that the aggregate performance of physicians or hospitals like them was at 85% or above, man, that motivated them to get to that 85% or above. And so what we really do is just help them through the continuous QI process. So we help them designate a champion, identify a team. The Heart Association has field staff across the country that have quality improvement backgrounds. And for some reason, we convene these regional meetings where hospitals come together in a room and share best practices. And I know there's lots of other organizations, even pharma companies, that have tried that over time. And for some reason, the AHA feels like a safe place to share kind of their dirty laundry, if you will. Like, this is our barrier, help us improve it. And they can, even with competitive hospitals that they've never sat in the same room with before, they'll, come into this room and go through a, plan, do, study, act process with them and help share best practices. And so what we've seen over time is that this process works. The way that we integrated health IT into it from the very beginning, so remember I said we launched it in 2000, so this was before mass adoption of EHRs. So we launched with a web-based data collection tool that had real-time reporting and real-time benchmarking, that also had clinical decision support built in. So we would show them as they were entering the patient data, which hopefully they were entering it prospectively while the patient was in the hospital, whether or not they had they were, as they were entering the care of that patient information, whether that was, green in compliance with what the guidelines recommended, yellow they had more things to check, or red, very simple that they were out of compliance and they needed to do something about that patient bone of it. But it really was kind of the programmatic wraparounds that we had, whether it was the workshops where hospitals attended or whether it was the recognition that we gave hospitals. So about 2005, 2006, we started taking out an ad once a year in U.S. News and World Report and congratulating hospitals that had reached achievement within Get With The Guidelines. And we had probably the first year was a 2-page ad with maybe 50 hospitals recognized. This last August, it was a 10-page ad. It's getting kind of expensive, with nearly 1,000 hospitals recognized. And so that really, I think, has also been a motivator for change for hospitals. So I'll just show you talk a little bit about some of the papers that have come out. So this is one of the studies that we actually did by Paul Heidenreich, which actually didn't even use our data. It looked at hospital compare data and put hospitals into 2 different cohorts. Those hospitals that were recognized by Get With The Guidelines, so they were in that ad in U.S. News and World Report, they had achieved certain benchmarks of patient care, and those hospitals that were not. So that could include the not cohort, included hospitals that were in the program but not yet recognized, but then also hospitals that were not in the program at all. And by looking at hospital compare data, we were able to say that the hospitals that were recognized had statistically significant lower 30-day mortality rates for AMI and heart failure. So we're really excited about that improvement in short-term outcomes. This is a slide that looks at the first 1 million stroke patients that were entered into the registry. And so in this one, we actually now have over 2 million patients. But from 2003 to 2009, these are all the performance measures for Get With The Guidelines stroke. The first group of bars over there is really thrombolytic therapy within 2 hours of symptom onset. So what percentage of eligible stroke patients got the acute treatment of TPA that arrived in time to get it? And when we started in 2003, that was at about 35%, and then in 2009, it went to about 75%, so doubled the performance of those patients. And then you kind of see similar kind of results, not quite as dramatic as that one, but as you go along. And then this last group of bars is the defect-free care. So the percentage of patients that got everything that they were eligible to get went from just over 40% to over 85% over that 6-year period of time. Another theme that we have been looking at over time is the effect of this quality improvement program on the reduction of healthcare disparities. And so we had published several papers over time that looked at that there was, kind of all boats start off low, if you will, and they rise over time, but there was still a gap in care even when all cohorts had an improved performance. So whether we were looking at age or gender or race or ethnicity, that's what we had seen for a while. This was a paper actually published by Mauricio Cohen, who was one of our young investigators, that showed an elimination of healthcare disparities. So again, over time, all boats rose and every cohort improved, but in the end, it was actually equitable care that in this case was experienced between Caucasian, African American, and Hispanic patients. And we've now published those results on gender-based, also on Asian Americans, and a couple of other different patient gender and age, I think is the other two. So something about this formula works. It's a bit of, everything's in the black box, and we're not really, if you take off certain things, what would work and what wouldn't work. But ultimately, it really is about using health IT, and especially this opportunity that we now have before us to really embed kind of what we know works, the individual components of health IT that work to improve care. But it really has to be I think we get a little bit lost in the details of CPOE and all of the meaningful use criteria, and ultimately it all has to add up to improve patient care, and that's, I think, what we have to keep our kind of eye on the prize for. So those look like they were NCQA slides, but no, they should have been AHA slides, but some of them ended up being that way. Integration. Yeah, integration, exactly. So I'll turn it back to Victoria. I don't know if there's other slides.
Well, not really, but we'll go with it anyway.
You're all now NCQA staff.
Exactly. So as we actually look at tying together our users' most expensive investment that we made in the EHR, we have to tie it to our greatest access, which is our physicians, our nurses, our staff, those who actually take care of the patients that come into our hospital. Briefly, this is just the deployment of BSHE, which is Bon Secours Health System, Inc. We started in February of 2008. We have 7 acute care facilities. We also have 11 additional joint hospitals that we're in ventures with, but we're in varying stages of completion. We didn't do a big bang with most of the hospitals that went up, so in some of them we have where it's just the ED, and others we have where it's, yes, the ED, the physician. We also have the nursing staff and some ancillary. But when we started looking at this, we wanted to see, of course, we've spent this money, we've put in this system, so now how do we determine that it's been beneficial for the quality improvements that we wanted to do? So we had in March of 2011, as you see, some interim reports, of course, for meaningful use, because we wanted to make sure that we would actually meet that measure, but we wanted to do a little bit more even for that. And we did a dashboard for all of our systems as we continue to go through. And you can see in August of 2011, we were able to successfully attest for 6 of our 7 facilities. So of course the question comes, well, why do a EHR? And we all know, you know, no matter what else that we say it's for, it's to improve the quality of the care of the patient. And so, and that's what it generally comes down to. You know, when you look at supporting the integration of care, when you're looking at clinical transformation, it all brings it back to that patient that presents either to the doctor office or to our ED or in our inpatient facilities. We'll actually go through this. This is just how our dashboard currently looks. We're always looking to improve upon this, and this was for meaningful use stage 1. And as you can see, for the most part, I mean, when we're talking about CPOE for medication, we only needed to have a threshold was 30%. As we went across the facilities, we were all at 100. But then when you go and you look into then what does that mean? It's, you know, having one patient have a CPOE for medication orders on the chart. How difficult is that really? So we wanted to actually take that and do more with it because, again, it's looking at that quality care for our patients. So what we actually then did, of course, we looked organizationally wise, we looked at facility, and then we did department level. And we looked at to see who was going to that low-hanging fruit that was then going to give us, if you would, the biggest bang for the buck that we put in. And so we actually then could go to the different departments, let them together with the physician actually see how it was impacting us and consequently impacting our patients. So we needed to improve. We wanted to improve. So in looking over the process flow, again, and this is just pictures of what I've already spoken about, it's actually looking at the data, vetting through it to make sure that what you're looking at and what you're going after is going to add value to what you want to come out with. And it's going through and seeing, so if something isn't quite right, asking the why behind the what and then sharing that. So as we looked, we went to doing observations because sometimes when you ask people, particularly if you ask nurses or doctors, so tell me, what do you do? they will tell you, but they will also leave out some steps because it's second nature to them. So, but if you go and you follow them, you say, but what about that? You didn't tell me that when you go in, you do X, Y, and Z. You just said you do A, B, and C. How did we get so far down? And say, oh, well, it's just something that I do. So you really need to actually go and observe the workflows, and we've certainly found that. Getting the collaboration of having everyone involved in the room and saying, so let's see what our opportunities are, and then going out doing not only the elbow training, but we actually, we created tip sheets that if, we're having all of these changes go in, let me tell you how that's going to impact your workflow. Let me show you how you need to actually go through that. And again, when we did the at elbow training, it was with whoever was impacted. So it wasn't just, okay, we're just going to be with the doctors, we're just going to be with the nurses. If it was the lab tech that was impacted, that's who we spent that time with until they got what they needed in order to make sure that their workflow was correct and that we would have accurate results, again, for that patient in the bed. Of course, the communication was in a variety of venues, several different methods, because we know everybody doesn't learn the same way. So some people, tell it to me. Others, no, show it to me. Others, I need you to do both of the things. And for some, I need you to do it several times before I get it. We did have some system change requests. I have it in one of the other slides, but I'll speak briefly to it now, because one of my little pet peeves is that what we got from some of our IT people is that the system is working as designed. Well, sometimes the system needs to be redesigned because it's not necessarily working for the people who's doing the job, which means it can't be working for the patient that they're doing the job for. Of course, continuing to look daily at our meaningful use measures, and not, we have where our managers do it, our analysts look at it, myself as the clinical informatics manager and our team, we look at it. But if you don't tell me about it, but quarterly or when I've made a mistake or when you've seen me drop, that's not the time to let me know that we need to make a change on something. And so that's why we do it so frequently and we give that feedback. I've learned positive feedback goes a long way with my doctors. So we actually do handwritten notes to those doctors who have exceeded the measures, and they have become the physician champions for our EHR, because it's that positive reinforcement that, hey, you're really doing a great job here, or I saw that initially your CMS scores going down, and you have really embraced it, and now they're going back up. And we want to thank you, and we want to acknowledge you for doing that again for the patient. So this here again is just a picture that's meant to show the collaboration. Again, we did the workflow observation, we do the tip sheets, the training, whether it's in a large room or at elbow training, which we find works really well. We also do weekly huddles, which, Katisha, if you would, I actually bought for you some of our weekly huddles that we do, because what we found in the feedback that we received from our providers and others is that, so when we have these critical problems that keep showing up, or or help desk tickets that's being placed, if one person is placing it, is a pretty good chance that it's happening someplace else. They're just not saying anything. They may have found a workaround, and we don't want the workaround. We want to improve the workflow. And so we actually use, as part of our huddles then, to actually take that information and to help to get it out for them. Can you just give my colleagues as well, please? Thank you. And so what we did for this past summer, because one of the things that we hadn't really focused on was the functionality and the legality that was involved with the EHR. So for a summer series, what we actually went and we did, we gave questions to staff every week, and we just wanted them to give us an answer to answer the question. We weren't looking for was it right or wrong, because either way it told us something. So if it helped us to increase our gaps educational, whether it was for policy or whether we needed to have that system redesigned. Of course, communication in meetings in different venues, our daily performance updates, and always the closing of the loop. There were times that we went out, we were told there was a problem, we fixed the problem, but then nobody knows that it's fixed, or they didn't hear that it was fixed because we told some people it just didn't make it down to the person that actually told us about it. So again, I already talked about sometimes the system, we're told the system is working as designed, but it needs to be redesigned. Earlier when we were on the roundtable discussion, we were talking about how the system itself is set up, and people still read from left to right was a comment that we actually had. And in one of our redesign that needed to be done, we had things going linear. And so we had staff that would go down and we said, well, why couldn't we make this transition of care for meaningful use? And it was because of how we had actually placed the after visit summary before the discharge instruction. So they're going down and we have them going in a certain order until they got to the last two, and then we told them in all our infinite wisdom, oh no, skip over to the last one and then come back. That makes absolutely no sense. So we did need to redesign that. Of course, we all know the EHR is always fluid, and there'll be constant changes going on. So our challenge becomes making sure that our staff and providers are updated. Of course, here we have meaningful use, but we've also then have done it with our CPOE as well. This is just an example of some of the tip sheets that go out. And of course, we have the best practice alerts that fire for our clinicians, and the doctors will tell you, they are having alert fatigue where they are just passing right through it. And so even though the system, very good system that will tell you, you need to do X, Y, and Z, or make the suggestion for something for the patient, but if it's just being blown past, you're really not getting any benefit of it. So we actually got together a group of our providers and others and looked at what were some of the things that we could actually take those alerts away that was not going to be a great impact or effect to our patient. And of course, closing that loop, the why behind the what, always doing the why behind the what. That's, I think without that, it's easy to tell me that I have to do something, but unless you let me know why I have to do it, you don't get quite as much buy-in. And so that investment that you spent multiple $1 million to get put in and to upkeep, you don't get as much out of it as you want. Of course, to sustain the performance is priceless. This is just some graphs of where we are as far as our performance. The thing to actually look here is when we went in and started doing the reporting and changing the analysis tool in late in April, you would see that we actually went up by 20 percentage points in May. And again, that's taking all those things into consideration, doing the observations, the actually asking the person that does the job, what was it that they were finding that we needed to do, and then making changes as needed. Lessons learned, and I don't think the most important one is on there, because the most important one, and Rick had spoken to this a little bit earlier, because when we say that, we look at the system, we look at the process, we definitely have to look at our people, but we have to bear in mind that our most valuable asset is the person that is still taking care of the patient. The computer can be a wonderful tool for them to use, but it's that patient. Again, if you can't measure it, you can't control it. And any questions, my colleagues, and of course in the last roundtable, I have some. Yes, sir.
I have a question. So maybe to take a half step back, what you're saying is you're trying to tie an IT investment into healthcare quality improvement.
Yes.
And to challenge that, I would say if I'm a hospital CEO and I'm being presented with a quality problem, look, you've got a quality issue with your facility. I don't know if my go-to solution is necessarily an IT solution. There are many other
May not be.
reasons or many other ways you can solve a quality problem that has nothing to do with IT. So putting that aside and then also saying, what was your motivation to justify the investment in an IT infrastructure like EMR? Because there could be other reasons why you would want to do an EMR, regulatory compliance, reimbursement rates going down, et cetera. So if you take those two where you're saying, well, you know, you don't necessarily make the case that you need an IT system for quality, and there are other ways to improve quality. How, for example, the executives in your organization decided, or what was the reason that they decided to say, okay, we want to make this investment?
And I think for us, it was a little of all of the above that you mentioned, because one of the things that our executives looked at across the board, we were not standardized in any of our 7 hospitals. We were used to our executives being able to go and meet and say, well, this is what we're going to do, exact the change, come out, and the change be done. But if I then had a nurse who traveled 16.25 miles down from the hospital that I'm based at, she may not have found the same thing, or may not have been expected to do the same thing. So we were looking for something that would give us the standardization that was there, of course, for regulatory as well, but we were looking at something to standardize care. Are we there yet? No, we are not. But that was a big factor when we went looking for EHR, that we wanted to standardize care across all of our hospitals so that where we may have been presented with an opportunity in one area, but you know, one of our other hospitals in either Florida and New York has really met that challenge head on, that information was not only just shared by word of mouth or through a meeting, but now it's in a system and we're all using it.
I'd like to respond a little bit to that. I think you're absolutely correct. I mean, if anybody is using the quality metric, if you will, as the only metric, they're going to be very short-sighted in their approach of any investment, I think, period, right? But IT specifically. My experience, I'm sure most of you have had this before, but you can't just throw technology into a broken process. You're just going to get broken results faster, right? So ultimately what you should do in any sort of, I think you're absolutely dead on with that. You can't solve everything with a hammer and everything's not a nail, right? In your case, that particular quality improvement I might be looking for might just be smoking cessation. It could be just a very simple brochure and a, check off the box, and it could be on, quite frankly, not to tout Microsoft, but an Excel spreadsheet. So, I mean, you've got to be, like you said, you got to weigh the pros and cons of that, but if you're really trying to get into the CPOE gig, I mean, you're not going to do that with a Microsoft Excel spreadsheet. So that's what I think you have to balance out which part of the quality spectrum you're looking at, quite frankly. But I think I know that, at least from the PCMH perspective, that's why at NCQA we look at it, it's the design of the delivery model first and foremost, and then use that technology where it's appropriate for the right team members, at that appropriate, what we call point of care, point of interaction, because just to put it in one office is not the solution either. It's just, you might as well put it in a closet.
Yeah, I guess the only flavor I'll add to that is it's becoming increasingly more difficult to do quality improvement without health IT. So they really do kind of go hand in hand, because you have to, in order to really do quality improvement, you have to measure where your baseline is and measure your performance along the way. That, is becoming very difficult without health IT.
I look at this as an opportunity to kind of jump on the bandwagon, because in fact in our breakout session in the last hour, you mentioned that at Bon Secours, the reimbursement for your EMR investment was actually
absolutely.
I have a question. So, and I'm going to ask you specifically, so as we're looking and we're forming an ACO, where then do you believe we should focus our health IT investments then?
Well, logically speaking, for me, she asked me where should we focus HIT investment. I mean, if you're going to form an ACO, and there's many flavors, as we know, of what ACO is, or could be, or might be, or, you know, you name it. As you know, we have standards for that as well at NCQA, in case you're interested in looking at those standards, of which we have 6 early adopters that are coming through this year. If you'd like to go find out more about that. But we fundamentally believe that patient medical home is a building block for good ACO-ness, if you will. Primary care still, in our opinion, in the delivery model structure, begins at the primary care practice foundation, which that's why you're seeing so many different models happen in terms of, you know, large group practices. You know, and there's a debate about, you know, how many do you need to have enrolled to make it actually work and be effective, and, you know, there's numbers of enrolled populations that people are going with. But fundamentally, you know, can you start at a, you know, medium-sized group practice and work your way up to the hospital integrated delivery system level and then, you know, health plan? The answer is yeah. You can do all those things. But it comes down to how are you going to manage the accountability of that care, and how are you going to know, going back to measuring it, how are you going to know that the care that you're providing is actually cost efficient? You know, cost effective, that value. It's both quality and cost effective. You know, it's not about more care, it's about the right care at the right time to the right folks. And so you can't really do that very well without good clinical information systems. You're going to need the foundational business information systems, which we all know, quite frankly, most of the folks have out there, if you will. That's the fundamental one, right? Billing systems. It's really going to be the clinical system, I think, implementation that your investment's going to be at. Yes? Sure.
What was really interesting to hear is your at-level training process, like, you know, the operational observation. I was curious what you observed or have done from a security and risk standpoint in protecting the patient data. You know, because we also understand, yes, there's a technology component to securing that, but what have you done and changed as far as the operational process? I know you guys are glad that someone is switching, but I would love to know more about what you've done because it's an interesting process for training.
So one of the things that we, of course, we brought in are security experts, if you would. And so when something goes into the system, we actually have our health system office risk manager, and they look at everything prior to it going into the system. The challenge with that is that risk managers are generally not medical in nature. So we actually then have to bring some of our medical people around too, because, you know, we have the whole thing where the system will self-log off and, you know, and we get the pushback, well, I can't, you know, I need for it to be longer than 10 minutes at a time, and we have where you cannot be on more than one, log into more than one system at a time. It just will not allow you to do that. Or I should say we now have that in place because, you know, we actually had an incident where that was initially allowed. And so it's getting with the security people and saying, okay, so regulatory-wise, tell us what would keep us out from trouble, and then going back, though, and explaining that again as we're doing the elbow training or even the classroom training of the why behind the what. Why is it that you now cannot log on, or why you shouldn't have actually been able to log on to 2 computers? Why is it that it's not acceptable for the doctor to say, oh, okay, I'm just going to log on and you just give me this information, I'm going to get called away, but instead I need you to close that computer down. And it's just communicating over and over and over again, and we do random audits, and that information is then sent back to the person or persons involved as well as their manager, and then we meet to have that discussion of the what, the why, the how, and who, and how that impacts not only the individual, but the organization and can impact our patient. Yes, sir.
So when it comes to that, I like this, you know,
Well, and I'll tell you, for our organization, what happened was, we had more of a challenge of the people that we put in place in IT and the medical, combining to say, okay, so if we have a patient safety escalation, that's what we call them, that's something that will impact patient care, that we need a rapid turnaround, there's a certain group that comes together, and it does not take 6 months for it to be done. There are things, so of course, that we put in that, some things are a nicety, some things we would like to have, but things that truly impact patient safety, we do have a faster turnaround, and that's because we've set up the process and the people in place. So when that occurs, when we know about it, either because we've had a help desk ticket come in and said, we're finding that, the EMR is rounding up on our babies. And so, when the pharmacist is looking at the medications and, it should be 0.05 and it's rounding it up to 1 for a baby that you can hold literally in the palm of your hand, we don't have that time to waste with that. And we have our builders, and we actually then come together and we get that corrected. Does that answer your question?
Well, it does. I mean, it certainly will hit the high points, but part of what you want to do is you want to experiment iteratively. You want to create a culture where everybody feels empowered to make changes in the work process and improve quality. But if it has to be, babies are going to die before it actually has that
Correct.
process, it becomes really hard to create across your organization the culture that says, you as a nurse on the ward, if you notice that there's a problem, we can make sure that we can visualize the system.
And to that point, prior to the EHR, we had that culture. So that if something was wrong, even on paper, it was the expectation, the responsibility of the person who found it to go and escalate that to someone that could do something about it. And I think what leadership then did, as we moved from paper to the EMR, we took that along with us. And so the expectation is that at any point in the process, be it a nurse, be it the lab tech that sees that something just isn't right, or even if we've gone through, we have end user testing, and as the end user comes in and they look at the new thing we're getting ready to improve upon, and they say, well, this really, it may work for the adults, but that's not the right thing to do when we are looking at the newborn nursery or the NICU. That process then doesn't go forth for the newborn nursery or the NICU. We can move forth on the adults, but we can't do it for a population that it's going to hurt, and it's the expectation it has been in place.
So I want you to do a study of your organization, and I want you to take a look at culture. Because
We've done that.
I'd really like to know whether the IT systems empower people to feel as if they could make a difference in quality improvement, or if they feel it as a barrier for them to be able to make it.
We actually did a survey. When we went, I did I want to hear from you survey six months in. Did it 6 months and then a year after. In the first 6 months, because for various reasons, what I got back was, no, they didn't think they could because they quite honestly were still learning the system. So they thought they had to just go with what was in the system at the time. We still had the expectation, but if you think it's going to hurt your patient, we were talking earlier, it's still that critical thinking part that's there as a clinician. So, you don't do something that from your practice, from your expertise, is going to hurt your patient. A year after when we did it, we found a lot more people who had put in that ticket and who had escalated it up to say, no, we need this fixed now, we can't wait. So, we saw that difference as that learning curve when we first initiated it until where, they got more comfortable with the process. And some or a lot of changes in workflow to say, no, we do need to make some changes. And please don't hear me say that we think we are where we need to be at, because we continue to improve upon that process. Because we want, you know, the doctors generally will let us know in no uncertain terms that, you know, this is not working for them. It's not necessarily that it's a patient safety risk. It's the reason that it's not working. Generally, when we get nurses in the ancillary, it's because they feel it's a patient safety risk that's occurring or may occur, and that's when we hear the cries go out.
All right. We have time for one more quick question. We are over, but I don't want to cut this
I'm
discussion.
sorry. So we actually do weekly change controls, and what happens that is generally this process is that if there's something that one of the end users you know, see or would like changed, they actually can put in what we call a help desk ticket. They call into the help desk, or they can tell one of our at elbow trainers. They can let me know, but the process is to have that ticket there so that we can actually track it, so we can know what that turnaround time actually is. Because we have so many hospitals up now and we're a system, we can't just be in our own sandbox anymore and change it, because what we now put in the system affects all of the other hospitals. So on that, we do still have a weekly meeting where all of the clinical informatics managers and teams get together, and we prioritize, you know, of course, patient safety being the first one, of, you know, what things we want to go ahead and have approved and put in the system. What we're finding, because at change control, because of course, you know, you have the ED, you have the OR, you have the ancillary, and there's just so many different systems, is that we can actually have up to 20 changes getting ready to come out. Now, that doesn't always impact everybody, you know, at the same time, but can you imagine if I'm the nurse and we're putting in maybe even 5 or 10 changes, that's going to impact me. So now you want me to remember on a weekly basis that we're getting ready to put this in, it's going to change, and now I need to go here and not here. Tell us how often we need to do this, because it was really causing some high stresses for them. And I'll tell you, no matter how many of the tip sheets that come out, or we put it in our huddles, you know, that we passed out there, and we go to the management forum, we go to staff meetings, we have the quarterly newsletter update, but it's a lot. They get overwhelmed. And so we have made the decision that we will only be doing it once a month now, when it's again, when it's not patient safety related, but it'll be once a month. When our tip sheets come out, we do highlight who's impacted by it, so that if you're a physician, you know, working in an ambulatory practice, you don't come into the hospital, you don't want to know, you know, what we're changing up there. If you're an ICU nurse, but it's something that's just impacting the ED, unless you're working down in the ED, even on a PRN basis, you don't want to know about that necessarily either. So we have highlighted that, and we do actually catalog the tip sheets. We don't do it by month. You can go into search and you can type in, like you can put blood administration and it'll come up for you. So because, you know, that just goes across the regions. So generally, we were doing it on a weekly basis. We were overwhelming, and so now it will be on a monthly basis.